¿Cuántos programas ya han hecho aquí? Muchos.
13 trabajos semanales también en video remoto. Welcome to Three Thoughts Son. Thank you for being here, everybody that's online. Thank you for the folks of Nona Media, Reese Lynn, MS2 here in Lake Nona Town Center, Juan Santos, and for the folks that are always here with us. And we have today a guest, Dr. Lourdes Benes. How are you today?
Hi. Thank you. Thank you for having me. I'm good, and you?
Doing well, thank you, doing well. Dr. Benes, we have a very important topic to talk about today, but before we jump in, can you please give the audience a little bit of background on who you are and what inspired you to get involved in the field of neurology?
Yeah, I'm Luli. That's my nickname.
Okay.
And I would like everybody to know me, not as Dr. Benes, but as a person, as you are, right? As everybody else is. So I am Luli. I'm the oldest of three girls, born and raised in Puerto Rico. My mom and my dad, raised us over there. We went to college over there, playing tennis. Always very important to study, but to play a sport and to be active, right? My dad is a GYN, a gynecologist, so I'm coming from a family of some doctors, my grandfather as well. And seeing what he did, or what he still does actually, got my attention into medicine. But I didn't know the field in particular, or the specialty in particular, until my youngest sister, had a seizure. So my youngest sister had a seizure when she was 15. I was 17 or so. And seeing her going through that, actually, is when I started reading about neurology to trying to help her. And that got my attention, right? So that's how I started studying medicine, and then I went into neurology. I married my college sweetheart, and we have been together since then. Did my residency in University of South Florida in Tampa. And then I had kids when I was older, actually. I had kids, I was telling you, Gustavo, I was 38 years old when I had him. And then Victoria and Camila, which are twins, I had them at 40. So that's how I started, and that's how I got into neurology, and got involved into that. And I was living my life that I thought it was the perfect life in Puerto Rico. Had a good job, used to live in front of the beach with all the family, and Hurricane Maria came, right? And I don't have to tell you the story, you know what happened, right? The whole island was affected, and I was not excluded. So I went from living in front of the beach with a nice car and everything to losing my job, right? Like my building was destroyed, literally. So waking up and going and seeing that is a very humbling experience. And having my kids very young, right? Back then, the twins were 6 months old. Gustavo was 2 years old, doing and making lines that were 2-3 hours for them to give you like a couple of bottles of water, and having to feed your kids like that is when we said, we have to move, we have to do something. Because now it's not about AC. If I have air conditioner, I can blow my hair or whatever, right? It's about feeding my family. And we came back. We came to Orlando. I keep very good relationship with my mentors. I graduated back in 2008, and I still talk to them frequently, and they gave me the opportunity again to start all over. They offered me a job, and actually I accept, but not as an offer for the job, but rather to start studying again. So I came back, and I did 2 fellowships in movement disorder and in cognitive, in memory disorders. And that's how, where I am right now. So seeing from adversity and opportunity, maybe. It was in front of me, and either I sit down and I cry and I, just see what happened and who can help me, or we move on and we do what we need to do. And that's what I did, and I have my family to back me up. My husband was there at my side. My kids were young, and that's how I end up here talking to you right now.
Oh, that's a wonderful story. Thank you for sharing. So let's jump in. You're in a field that, at least to my eyes, is getting more and more attention, and for all the right reasons, and in part because of technological advancements that allow doctors and researchers to learn a bit more about the brain. But if you ask the average person to say what's the difference between neuroscience, neurology,
It's very confusing.
It's very confusing, right? So correct me if I'm wrong, but neurology is kind of a subset of neuroscience in the sense that these are MDs, neurologists are MDs, medical doctors that study the maladies, of the nervous system, right? Whereas in neuroscience, you probably have a PhD. Some neuroscientists may have an MD, but they're more researchers.
That's correct.
They're doing studies. They're trying to study how exactly the brain works.
Yes.
Right? Am I on track here?
Yes, very much so. So I see us as a team more than anything. We're collaborators. So I'm in the trenches. I'm seeing the patients, and they're in the research, giving me the resources to be able to treat people. So I think we both collaborate. We need each other. And yes, we go to medical, in my case, the neurologist, we go to medical school, and after we do our residency in neurology, that is 4 years. And basically is everything related to the brain and the spinal cord and the nervous system. So that includes also the nerve that, the peripheral nervous system that go to your legs, to your arms. So it's not only on the brain, but it's basically studying the main computer, right? And it's a very, very challenging field because we don't see, right? It's one of those, if you go for a dermatologist, they can just do a biopsy and see it under a microscope. If you have an abdominal pain and they don't know what it is, they can do an exploratory, right? A surgery to see what's happening. But for the brain, what do you do? Are you gonna open the head and then just, it's not easy. And that's why it has been, I would say, like a dark science for so long. And it's a field that a lot of people don't like to go into because they don't know, right? Because we don't know. We still don't know. Even internists that they study their 4 years, when there's a neurological problem, they immediately refer the patient. They don't even try what's going on over there. Nowadays, as you said, as you very well said, we do have advances that include radiological technologies that can help us see what is happening in that black box, right? So a black box in an airplane, you only see what's going on when the airplane is, right? So that's the brain, basically. But right now with technologies such as PET scan, for example, so nuclear medicine, we can see what's happening in the brain. With genetic testing as well, we know what's going on. So we are seeing a little bit more, and that helps us also not only understand the pathology, but look for different alternatives as treatment, and more so for prevention. A lot of our conditions that we treat in neurology, most of them are chronic. That doesn't mean that you're gonna die because of the condition, but you die with the condition, right? So I would say all of the patients that I see, when I introduce myself, I tell them, you're married to your wife and you're married to me. Because this is until the end, you know what I'm saying? We're gonna be here together because most of those conditions are chronic. But giving them hope and being able to know that now we have treatment options that can help prolong your life and live a very good quality of life is important, because it's not a matter of living 100 years and 30 of those in a nursing home, than rather to have good quality of life of whatever you're gonna be living.
This is very interesting. So my father is an MD as well. He's retired, also an OBGYN. So I do have that. It's, I guess for those of us who are children of doctors, we grow up in a very special household listening to conversations. And I did not become a doctor to his disappointment. I became an engineer. But you said something that I want to immediately dive into, because I think one of the benefits of, and please keep me honest, one of the benefits of the technological advancements that give you tools to understand better what's going on is the fact that we can now have a little bit better understanding on what to do so certain things don't happen. The whole world of prevention,
Yes.
right? For a long, long time, medicine has been a very reactive practice where, the person has to get sick and then you treat the disease or the ailment. And now we are getting into exciting times because as we're learning, we're also learning some of the causes, and we can teach prevention. In your day-to-day, do you see the same thing? Do you see yourself helping people prevent? Or are you mainly occupied helping people recover or live with a disease?
So that's a very good question, and I love that you actually did it. So both, right? Because nowadays, giving hope and alternative for somebody that already have the condition. So having the tools of different medicines that can help is pretty good, and it's very rewarding for the patient and for myself. But my special project and what I believe 100% is in prevention. So I think they should go hand in hand. I would not say like we can do just one and not the other. But definitely, if I have to put my money on something, I would do it on prevention. So prevention, I have a hard time convincing the patients about this. It's nothing that we are wired or used to hear all the time. We know about the conditions, we know about the medicines, because unfortunately, the things that are on the media, on the TV, on the advertising, are the things that are being paid or advertising by pharmaceutical companies. And nothing wrong with that, we need them. I'm not going against them. I'm just saying that, then who talks about prevention? I mean, they're not gonna pay me to talk about not getting the condition, but they will pay me to talk about the medicine that is there to treat the condition, right? So it's in podcasts like yours that we actually can get to a lot of other people that are listening to us, and that actually can start, knowing that there's something happening, that there is something going on, to get educated on that, to look for good information. Where do I read about that? Who do I listen about that? Where do I go? Where can I check my brain, in my particular case, before the condition happens? You know when you have to do your colonoscopy. I know when I have to do my mammogram. Do you know when you have to go and check your brain?
No.
So you wait until you have the problem, and then you knock on my door. And then, yes, I have the medicine to give you. But that should not be the process, right? That should not be the process. What can we do on time to see, how can I prevent certain things? There's certain things that you cannot do anything, and I cannot do anything. I cannot do anything with your genetics. I cannot do anything with your age. And they're both risk factors for memory problems. Let's put that example, right? But there's a lot of other things that can be done for other risk factors. They're time consuming, and they're not nice, or they're not easy, and we're used to be in the comfort zone, right? So you give me the medicine for the cholesterol, rather than me going and walking or running or doing the diet, just because comfort is easier for us. But yes, if we're educated about it and we hear how it is and we put our effort on that, a lot of the conditions can be prevented, and the ones that are not preventive because are genetic, for example, you could at least, the goal would be to be independent the longest, that you can manage the condition that you have, but that you can remain independent the longest period of time. That would be the goal for those risks that I cannot change.
So let's talk about the conditions. We've been talking about preventing or dealing with conditions. What are some of the conditions that fall under the umbrella of what you do?
So in particular, I did the fellowship in cognitive and Parkinson's. There are two different conditions, but both of them are neurodegenerative. So in movement disorders, there's a very broad amount of conditions that go under that umbrella, that goes from Parkinson's and Parkinson's-like symptoms or Parkinson's-like conditions. In the Parkinson's-like, we have multiple system atrophy, we have corticobasal degeneration, we have dementia of Lewy body. There is a gamma of those. We have essential tremors as well, Huntington's. So movement disorders is a field on its own, right? But more common, we have the neurodegenerative diseases such as Alzheimer's. So dementia, issues with the memory in general. In particular, Alzheimer's affects 6.7 million Americans right now, and those are the ones that have been diagnosed. You can imagine how many have not even gone to the doctor, and they think that what they have is normal for their age, or they just have been misdiagnosed with a psychiatric condition. How many of the patients are under the psych ward and are being labeled as they are, demented or crazy or however they want to call it, and they never reach, or they may have another diagnosis. So that's a condition that is just becoming more prevalent, and each year we have more and more cases. And not even talking about our population, the Hispanics, that we're even more at risk compared to the white Americans, and the same happened with the African Americans. And even though our risk is higher, most of them don't get to the doctor. They don't do it because they're not being understood, because they're afraid, because even the term of dementia, for us, it means something different, right? It means you're out of your mind, right? Mm-hmm. So how do you do that? How do you do that approach? How do you tell them, go and be checked? We are at a higher risk. It's been very, very difficult for the doctors to spread the word about this. So under these cognitive disorders, Alzheimer's is one of them. It's the most common cause of dementia after 65 years old, but there's other types of dementia as well. And by the way, Alzheimer's can happen in younger people. It's just that it's less common. You can have vascular dementia, and that vascular dementia is due to strokes, and the same risk factors that would affect your heart can affect your brain. Frontotemporal dementia is another type of dementia that usually presents with behavioral changes, so different from Alzheimer's, right? Then you have Lewy body dementia that have a lot of hallucinations, but also have Parkinson's-like symptoms. You have dementia due to other conditions, even due to traumatic brain injury. So there's the list is huge, right? But the most common one, and that most of the people will hear about, is Alzheimer's, just because it's the most common one after 65. Mm-hmm.
So there's a lot there that I want to cover. So you mentioned Lewy body a couple of times. That was the Robin Williams disease that took his life.
Yes, that's correct.
It was incredible for me to watch the special, because you can't see it until after the person has passed.
Yes.
So there's a subset of all the stuff that you talked about that only can be seen or diagnosed after the person has passed, if you get a sample of what was going on physically in there. Mm-hmm. And you also mentioned plaque, so I want to kind of correlate that. You mentioned the same type of problems that you can have cardiovascularly related to plaque. There's an equivalent correlator in the brain where the plaque accumulates, and now neurons can't talk to each other, and that creates all kinds of dysfunction. So it seems to be, correct me if I'm wrong, that if from a preventive point of view, if I do the things that I need to do with my diet and movement to help my heart, I'm also helping my brain.
That's correct. That's correct. And let me clarify that a little bit. And you're correct about that, and we're going to talk about that. So remember that the heart will pump the blood also, obviously, to the brain. So anything that affects the heart, anything that would cause the arteries not to be like narrower, would actually cause the same problem in the brain. Now, the arteries in the brain are smaller than the ones of the heart, right? So they don't need even that much to cause a problem. And sometimes you are affecting the smallest vessels of your brain, and you're not even aware of that. So you can have somebody that is just showing up in the clinic for a headache or having some memory problems, and you see that MRI, and it's full of white spots That means small vessels that have been affected for some time, right? And then you have to look at the risk factors, and if you see are the same ones for the heart, so that would include cholesterol, that would include blood pressure, that includes as well, any kind of issues with the heart, like heart failure or arrhythmias, smoking. It would include also air pollution, not sleeping well, stress. The same things that affect the heart would affect the brain. Now, the plaques, so that would be cholesterol plaques that I was saying inside the arteries. Now, there are other plaques that we can talk about, and that is for Alzheimer's in particular. So Alzheimer's pathology, we think, is multifactorial. It has a lot of different things that may be happening, and we're finding more and more different reasons. For the longest, we know the period of time that tau and beta amyloid, which are two different proteins that can accumulate in an abnormal brain in the brain, are the main pathology of Alzheimer's. So beta amyloid would be the plaques in between the cells, so they would not allow the cells to talk to each other, and tau would be the ones that accumulate inside the cell. So they basically kill the cell from the in to the outside, right? So they both do a lot of damage. We think tau might be a little bit more for cognition, the problem, because right now we do have medicines that would slow the progression of the condition by removing the plaques of beta amyloid, but we only do that for about 30% or so. So what else is that 70%? Is that tau, or is that what? And we have found that actually vascular process in the brain has something to do with that, and inflammation as well, insulin resistance in the brain as well. All of those things are linked to a higher risk of having Alzheimer's. And that's the target of the newer medications. They're looking for the GLP-1 medications, like the ones that they use for diabetes and for weight loss. They're using it for Alzheimer's. Because if in fact there is an insulin resistance in the brain that increases the chances of having Alzheimer's, why don't we treat that and we see what's going on? And so far, the result seems to be very promising. So we may be using those medicines in the near future to treat Alzheimer's as well. And the same with the vascular process. We have seen how vascular process actually are linked with Alzheimer's. So you see how now the pathology that was before thought that it was just beta amyloid or tau, now we're seeing other things going on, is still in research. But this conversation that I'm having with you, I was not having it a few years ago. These options about telling you that either you can get this through research or outside at the office, at the clinic, you can get two medications that are being given IV, one every 2 weeks, the other one every month, and that would actually remove those beta amyloid accumulation in your brain, and now you can slow the cognitive decline. Listen, we never talked about this before. We were talking about medicines that just can help a little bit, but we're not treating the underlying problem. So that's promising. I know we're not there yet, and there's side effects that can happen from these medicines, and not everybody's a candidate for that. So we need, unfortunately, to handpick who is the best patient to avoid the side effects that could be brain bleed or edema of the brain, in between others. So that's what is important to know, what is normal for age and when it's not normal for age, because we have a window period to give those medicines. And it's not only about medicines, the message that I want to give is about a lot prevention, et cetera, but those patients that actually were doing their prevention and got on time in the clinic, the outcome and the options are different. So, but if people don't know about it, they just don't get on time, right?
Yeah. So I'm going to throw something at you. I'd love for you to expand on it, because I'm trying to live a life of more and more prevention, and I think I have hope that a lot of the things that we see in our parents that we're not going to see in my generation, and that when I get to my parents' age, that the things that I suffer, my kids won't suffer from because of advancements in medicine and technology. There was a paper I read, it was an NIH paper a while, it was probably 4 or 5 years ago. There was a study that was done with, about Alzheimer's specifically, where there was a number of someone had figured out that there was a segment of the population that didn't seem to be getting Alzheimer's at the same rate as others, And this was these nuns that work in convents out in some mountain somewhere, and they try to figure out, like, why is this happening? Like, how are they, when even though they grow older, why don't they experience symptoms of Alzheimer's? So they did a study. I believe the number was 80 nuns that volunteered for their brains to be studied after they passed away. And what they found out was that they, from looking at the pathology of the brain, they had all the plaque and all the things that would have indicated that they should have had Alzheimer's, except their behavior did not, was not, concordant with Alzheimer's disease. And that led to a series of other studies. The conclusion was that, well, this thing called neuroplasticity, right? I mean, these ladies live a life of a lot of movement. They're always moving around because they grow their own food, and they're cooking, they're cleaning, they're going walking from town to town. They're eating very healthy because everything they eat comes from the ground, right? They rotate these things around, so they're challenging themselves. They're challenging the brain, right, in ways that a lot of people at that age no longer do. And the conclusion was that because they kept challenging themselves and challenging physically and mentally, and they slept well, right? The sleep aspect, which was also key. Their brains found ways to rewire themselves through the neuroplastic process. So even though they had the physiological evidence of Alzheimer's, they weren't suffering from it. What are your thoughts on that? And did I understand that correctly?
Yeah, you understood it very well, and that's part of that project that I was telling you that I truly believe in. That is neuroplasticity, but I'm gonna tell you an example, the way that I explain my patients. And I use the example of the hurricane just because it struck me, and I think everybody understands that. If you're in my neighbor, and they tell us that a hurricane is coming, I put my shutters, and you didn't. I went and bought, I don't know, water. You went and bought beers. I put you as a bad guy, you see. and I got all what I need, or what I thought that I need to survive, just in case, right? It may not come, but let's just put that it was a hurricane category 5, and it hit us. But then I was able to survive longer. I was able to manage. I mean, I put my shutters, I had my water, you were suffering over there. We got hit by the same hurricane, but the prognosis was different. And I looked much better than you did, just because I was prepared and you were not. So that's the first thing, and I want to talk about cognitive reserve before I talk about neuroplasticity. So cognitive reserve is how I prepare myself for like future events. Is that what I just told you? I bought the water, I have my food, I put my shutters, I was ready just in case. So having a higher or a bigger cognitive reserve, it protects you, even though, in this case, the example that you said about the Alzheimer's and the pathology of it, if I have a higher cognitive reserve, I'm able to manage better clinically. So I can live independent longer, even though I may be a little bit forgetful. So we see that, for example, with the doctors, with the lawyers, with whoever after school, after their 12, high school diploma, continue to study, continue to learn something new, are challenged by new things every day. We didn't see that much, unfortunately, on our people, the Hispanics. And you know why? There's a higher incidence of diabetes, there is a higher incidence of high blood pressure. These people work usually 2 jobs because they have to sustain the family. Most of them have to quit, and don't finish even school. So all these other things that I'm telling you are protecting us. So that's the first thing, having cognitive reserve. Second thing would be neuroplasticity. So now, on that brain that perhaps have a very good cognitive reserve, something happened. It could be a stroke, it could be whatever you want, right, in that area. People that have a lot of cognitive reserve are already having a lot of connections between those cells. So I have different paths to send the information from here to here. It's not only one road. They build connections using different cells around them just to get to the same place. So if this connection is lost because of a stroke or because of Alzheimer's, I still can use other connections around. But not only that, the brain can literally, it's like move around and create new connections in between the cells where the damage is or the damage was. But you can do that in cells that are healthy, in cells that can actually, yes, do the connections. You cannot do that in somebody that is smoking, that is obese, that have sleep apnea and doesn't use the machine. That capacity of growing new, of growing new connections is not going to be the same. So neuroplasticity is a very, it's a trending topic and it's very good. But we need to do, it happens in a healthy brain. It doesn't happen just out of the blue, in somebody that is doing drugs and is, in an exposure of a lot of toxins and that have uncontrolled sugar and all the things that we're talking. That neuroplasticity is not the same, it's not as good as it could be. So we need to have, and we need to work out for that. And having good cognitive reserve, I'm sure that neuroplasticity is going to work beautiful, and it works forever. It's not that it works until you're 60. We have 80 years old, 90-year-old people building new connections in their brain. And we know that because after the stroke, the way that they recover, right? And you see them and you're like, wow, you couldn't walk, 1 month ago, and look at you right now. We know that those connections are being built and are not age dependent. So there's something else that helps with that. And you mentioned a lot of them. Those are the modifiable risk factors. 45% of the risk factors can be modified. And I told you we cannot modify the age, we cannot modify the genetics, but learning something new, and something new is not, I have patients that will tell me, I play Sudoku every day. That's only gonna get you good at Sudoku, that's it. That's that road from here to here. I need road here, I need another road here, another one here. So I need something with music, something with arts, something, so different areas of the brain creating those connections, okay? I'm not telling you to stop doing the Sudoku, but it's just not enough, right? Mm-hmm. Learning something new is challenging, but it's good for your brain. To put you in that challenging position, it makes you try to figure it out, right? And you get tired, and you sit down, and you drink water, and you go again and do it. That's why when we see that the patients actually retire, when they really retire, their brain retired as well. So you can slow down a little bit, that's fine. But like completely do nothing, I mean, that's what you're gonna get. You get slower, your thinking process, you know what you wanna say, but the word is not, it doesn't come out. You know where you store the past information, so the long-term information is the last one to be affected, because that one is already stored there. Mm-hmm. It's the new one that you have to kind of store that becomes a problem. And that starts with even basic stuff about checking your hearing. Sometimes if you don't check your hearing, if you don't check your hearing, how do you know? How can you store the information? But not only that, socialization is so important that if you're not hearing well, what do the people do usually? They would just kind of isolate because they cannot participate in the communication, right? So social isolation is another huge thing with memory problems. Other things, you mentioned sleep. During sleep, you consolidate the memories, but also during sleep, we get rid of the trash that is produced from the cells. So if you sleep 3-4 hours and are not, enough, obviously, you start to build up all that garbage in your brain, and at some point, you're gonna pay it up.
As the lymphatic system, right?
Yes, that's correct. That's correct. The diet you mentioned, that's so important. How many preservatives and everything that we see in the diet. That's why probably those nuns over there that are, taking care of their own food, and so all the pesticides, all the herbicides, all the things that the food has, it affects our brain. Toxicities as well. Interesting, we talk about like the veterans and how they have been exposed to, for example, Agent Orange, the ones that went to Vietnam, Gulf War, and Camp Lejeune. All these things affect the brain, definitely, and they're linked for a higher risk of having Alzheimer's. But nowadays, there was actually a very interesting study published that they follow 1.1 million people in California that live nearby the wildfires, and they follow those patients for 10 years. And the people that were near the wildfires actually have a higher rate of dementia. So how even where we live, right? Like they affect us, definitely. Depression and anxiety is a huge one. Depression, anxiety, stress that increases the cortisol level in your brain. All of those things are linked with Alzheimer's. Deficiency of certain vitamins, for example, and other things like thyroid, like hormones as well. I'm sure that you know the changes in the brain, especially in women, we have seen it since their perimenopause. That decrease in estrogen, we start seeing so much changes that we know, can lead to Alzheimer's later. So there's still a huge field that we can work on. I'm sure, I know the researchers are working on to see how we can attack those problems many years before that condition or those symptoms start to happen. So you see how many, smoking, for example, blood pressure, we spoke already, diabetes as well, so uncontrolled sugar, cholesterol, vision problems. All of those are modifiable risk factors, and I think that's where we should actually do something and try to, prevent and try to put our money on that. Because as I told you the example a little while ago, if we're gonna get the hurricane, we're gonna get it. I cannot change that. But if you're prepared, the prognosis and the outcome is gonna be different.
One of the things that gives me hope in this field, and it's actually pretty prevalent in other areas of medicine as of late, is this idea of looking at the individual as a whole, right? We, for many, many decades, we had this reductionist medical approach. The cardiologist only looks at the heart, and the gastro only looks at the gut, and I see more and more the medical world getting into more of this functional integrative approach. A lot of the things that you have mentioned, correct me if I'm wrong, seem to fall into what people categorize as mental health, right? Yet we're talking about it from a neurological point of view, right? And one of the things that I was wondering in your practice is, do you see yourself zooming out a bit more? For instance, let me give you an example and see, please keep me honest. We know the nervous system, has a number of different parts, right? And you have the parasympathetic, and you have the CNS, the central nervous system, and then you have, as of late, the enteric nervous system, which, you have all these neuron-like cells in the lining of our gut biome, right? Of our lining of our gut. So all of a sudden, if we don't eat well, our gut gets imbalanced. That shoots up signals through the vagus nerve straight up, and now hormone regulation in the brain goes out of whack, right? And I'm just thinking I'm having a bad day, but it's not a bad day. I'm just not eating the way that I'm supposed to be eating. I'm damaging, my a second brain, as they call it, because of what I'm choosing to eat, or because I'm choosing to eat during a moment of stress or anxiety or an anxious moment, right? Do you see yourself in your practice applying these types of principles and giving your patients this type of information so that they can then make changes to their ecosystem? Because at that point, then it's about the epigenome, right? It's how do you architect a household type of life, at home or at work, with family, with friends, co-workers, so that you give yourself a better chance?
Yeah, you mentioned a lot of good points, and let me just start. You mentioned mental health, and so there's a difference between mental health and brain health, although they go one-on-one together, but mental health is more behavior, so it's more anxiety, depression, bipolar, so all that would be mental health. Then brain health is more cognition, but they go hand in hand, okay? So that is with that. And you were mentioning about like we are one body, Unfortunately, for good or for bad, we have too many subspecialists, and I'm one of them. So it's not that I'm praising for it, but but it's true. I mean, you have to treat the patient as a whole. And one downside that we have here in Central Florida, I would say that there is a fragmented system, let me tell you. So you as a patient will go to a cardiologist here, an endocrinologist there, and a neurologist here. So we're working on seeing how we can combine the medical records, share information, and all these things now with AI and et cetera to help get that information from all the different sources, because at the end of the day, as you mentioned, whatever happens here is going to affect over here as well. So yes, so the important that you mentioned about like the enteric system and how neurological conditions are actually related to that. We're seeing more and more evidence on that, not only from the memory standpoint, but we see it even for migraines, for example, and that we do diets for migraineurs actually that may have absorption problems, et cetera, and that's one of the triggers for them. So we see it not only in memory, we see it in migraines, and in Parkinson's, for example, patients have decreased absorption even of the medicine. So how they are taking pills and only 10% of the medicine of the levodopa will reach the brain, and they have delayed gastric emptying, and then the pill is just sitting there and we don't know when they're going to absorb the medicine, and we see the symptoms that they just fluctuate. So whatever happens in the rest of the system, yes, it does affect the brain. I'm trying to educate the patients as much as I can. Obviously, it's being hard because you're trying to change somebody's, belief for the longest. And unfortunately, as well, there's good information, but not as good information online as well. And everybody reads or looks in Google, so I get a little bit of a pushback, but I didn't read that. It didn't say that over there. I didn't know. How come the migraine come because something that I ate, or how. And so it's challenging, because on top of that, we have this amount of time to spend with the patient. I wish I could be the whole day with one, but education is a huge deal, and for me in particular. So I'm looking for different ways to educate the patient, not only at the clinic, but this is one of them. That's one of the reasons I'm here. I want actually people to listen to what I have to say. These things that I can, maybe I don't have enough time for, being 2 hours with each patient. But this is, yes, I'm a true believer about that, and I try to educate, but yes, we do get some pushback, especially, because it's not the comfort zone anyways of the patient. When I tell you, just don't eat this or don't eat that or do exercise, how much difficulty I still get from the patients to understand that it's not only the diet but the exercise, how good it is. Mm-hmm. Most of them will say no, I didn't see any benefit. So I mean, the benefit of exercise have been tremendously explained and in research and all that, not only for the heart or for the weight or for the sugar. It also helps with the amount of oxygen that gets to your brain. It helps with the amount of neurotoxins that are being produced, like for example dopamine, and so there is a lot of benefit. I mean, I don't know if it is because it's free that everybody, maybe they have to pay, or but it's still like the basic stuff. It's a challenging to actually try to. I feel sometimes seeing myself trying to convince somebody. Mm-hmm. Some of them are open to the option and they will try it, but some of them, especially the elderly, are still a little bit more problematic to do so. And now that we mentioned exercise, just really quickly, cardiovascular activity is really important, but strength as well. So adding strength exercise is really important to all this.
So let me throw something at you and see if this resonates and you can expand on it. This is one of my favorite topics of conversation, is the evolution of the human brain. You talk about cognition, is central to what you do, is that cognitive ability, cognitive reserve, as you mentioned mm-hmm. earlier. And we live in a very different world today than when this version of our brain evolved. Our ancestors, depending on who you talk to, the current version of our brain is either anywhere between 150,000 to 300,000 years old, right? And evolution takes a long time. But our ecosystem has changed dramatically. Mm-hmm. And last time I checked, the brain doesn't create new areas of cognition to deal with new social problems. The brain is basically processing everything that comes as it comes with the hardware that it has, mm-hmm. right? Because evolution is very slow. and social change is very fast. So we are at a disadvantage, right? Because we are bombarded every day, from our devices and the news. Our ancestors didn't know what was happening 3 miles from where they lived, right? And we know what's happening in Ukraine. We know what's happening all over the world at any given point in time. And the brain is just doing the best it can to keep up with managing all that input that wasn't prevalent in the past. Do you see it that way as well? And if so, can you expand a little bit?
Yes, and that's where neuroplasticity comes. That's exactly, that's the definition of neuroplasticity, how our brain adapts to the new environment, how that brain actually with a new challenge would actually, at the beginning is difficult, but then when you're repeating it and when you're seeing it again and when that stimulus keep coming, that's when then this part of the brain start making connections with this one, and it's like, oh, this is what is happening, right? So that's what's the principle of neuroplasticity as well, like how our brain changes in regards to the exposure to different challenges. However, the challenges or the exposures that you're mentioning would bring a lot of stress as well. So it's not the same to get an exposure to something, to being at the beach or whatever, and that's new, and that what you mentioned about this news that we get from Ukraine or from, so the exposures can be good and can create neuroplasticity and connections in a nice way that you're gonna be able to use, but the exposure can actually be the opposite, right? So how do you handle the opposite information, and you choose what to hear, what information to, which one to actually pay attention to, or which one you're just not going to pay attention to it because it's going to be detrimental for your brain, because it's going to increase your cortisol levels and it's going to increase your blood pressure, right? So how much of that also you would actually try to internalize. But that's when we need to know also how to manage these days that we're living. That's when you need to know how to manage the stress that could be done in a different way. There's people that would pray. There's other people that would visualize that they're in a place that they'd like to be. There are others that do yoga. There are others that meditate. There's different ways of doing it, right? But definitely knowing how you're going to handle the stress that is around you is very important, because it's going to affect your brain in a negative way as well.
So how do we go from that, right? So we've talked a lot about these things that we can do to kickstart the plasticity process, to get exposure. The way that I explain it to my kids at one point is like, it's like going to the gym, right? If I go to the gym and I work out for an hour and I go home and I look at myself in the mirror, what do you see? Nothing, But if I do that in the next day and then I come home and I look at myself in the mirror, what do I see? Nothing. Because it takes months of consistent work before the physiology starts changing and I start seeing those results. And with the brain, if I consistently expose myself to things that are either not challenging enough or that are gonna make me negative, right? Over time, that's what the expectation is. And that's going to lead to a lot of problems. So if I'm going to change myself, I can do all these things, but I have to be cognizant of the fact that the benefit is delayed.
Yeah.
The benefit is delayed.
Yeah.
But that's for a healthy person. Now, what happens if I'm already experiencing a disease like Alzheimer's or like Parkinson's? Do these tools that could help a healthy person possibly prevent some of these diseases? Are they also useful for someone that is already experiencing the disease?
Yeah, so the sooner that you do it, the better. If you start at age 7, at age 6, you're gonna, that's gonna be there, and your cognitive reserve, you're building it up. So the sooner that you start, the better. If it's never too late to start, but the benefits are not gonna be the same if you already have the condition, right? Because if you already have it, to build those connections, as we were talking, is, first of all, the patients, if it is a little bit more advanced, they're not able to do
Correct,
what we're
yes.
talking, right? So assuming that it's early stages, that they're able to do it, Yes, they are able to do it. However, the amount of abnormal deposition of these plaques or proteins that we're talking are detrimental to them as well. So my message would be doing it the sooner before even the condition is there would be the best, but not because you have it, don't do it. I mean, as I tell the patients, the moment that I don't tell you to do this is the moment that you really are in that stage in the condition that I know there's not a lot that can be done anymore. So the sooner the better. Mm-hmm.
What are you excited about as far as the future? You mentioned AI. Of course, everybody is either excited or petrified about it. But from a neurological point of view, from your day-to-day work, what are you looking forward to be able to use to help your patients either prevent or deal with a disease?
So what is exciting about neurology right now, as I was telling you, is that the conversation is very different because we are seeing what's happening. So prevention is number one, and being able to educate the patients much before what is the right age to start. The right age is when you start at school. Let's put it that way, and you just don't stop, right? But it's exciting also to have different tools to see what's happening, and it's exciting also to know that there are different medications that are out there in case we need them as well that could slow the progression, that we're heading into the cure of conditions that didn't have a cure before. So hope is there as well, and integrating artificial intelligence that can be useful not only for our doctors but for patients. I tell patients, try to learn as much as you can about that, because actually that is there to help you stay independent as well the longest. Now, I cannot tell you to do that if you're already in an advanced stage of any condition. So getting to have these gadgets as tools to help you as a patient as well is pretty exciting. So I'm seeing myself right now giving hope for conditions that didn't have any hope before, and seeing prevention as a tool as well, and more people are willing to listen to this. So I think that we're gonna start seeing cures for many conditions that we didn't even have an idea that could happen before. So working hand in hand and collaborating with other doctors, collaborating with not only the patients but also their family, their caregivers in particular, giving, talking to them, talking to humans, and that part of holding hands together. I see a good future in neurology. We're not there yet, but I see it's gonna come.
How do you see, you mentioned something that I think is very important. You mentioned two things that are very important. One of them is community, right? And there's plenty of studies, including the Blue Zone study, that actually one of the conclusions was that community is very important for longevity. Right? When you know that there are people around you that have your back in a community. And community these days is so hard because everybody seems to want to be isolated. You work and work and work, and then you go home, turn Netflix, and then continue the bombardment, right? Through the eyes, which in itself is a bit of a problem. A lot of people don't know that the optic nerve is actually part of the nervous system, because our retina, as we are being developed in an embryonic stage, is actually neuronal tissue. There's neural tissue in our retina, so it is considered part of the nervous system, which means that it matters what we expose ourselves visually too, because things start happening or not happening as a function of what we expose ourselves to. But you mentioned community, and you mentioned caregivers. So now you have this whole world that gets forgotten. Whether we're talking about Alzheimer's, or we're talking about Parkinson's, or whether we're talking about autism, right? The people that are experiencing these conditions have relatives that are living with them, trying to help, and they also need resources and help to be able to keep giving love to their loved ones and keep trying to improve their quality of life. I know I'm asking a lot, but I mean, do you in your practice see this, and is there anything we can do better in that space?
Yes. We actually have caregiver support groups in our practice. We have one for Alzheimer's caregivers, and we have another one for Parkinson's caregiver, actually in Spanish. Um, Caregivers, I see it as that's the guardian angel. That's your shield. That's you're able to manage so much, but then if you don't have that other at your side, most of these conditions that we're talking, you're not able to handle by yourself at some point in life. So choosing who's your caregiver is one of the most important things, starting with. It doesn't have to be your partner necessarily. It could be a child, or it could be one of your children, or it could be somebody else. But that's someone that you choose as part of your team, even though you don't have any problems yet. You're already looking who's gonna be the one, right? Mm-hmm. Who's that? Because there's some people that you may not want to have around you, even though they're family. So choosing who's that person, that's I see it. If it is a team, as I see this, and the patient is the leading player of that team, this person is just the guardian, the one that protects the blind side. You can have a quarterback over there, and it could be a very good quarterback. But if they don't have anybody protecting their blind side, they cannot do anything. They're just going to be all the so that person is that important. That person usually don't sign up for that job. So nobody called them and said, when you're going to marry to this person that is going to have Alzheimer's in 2 years or 3 years. Or so when you do it because of love. Let me tell you, that's the only thing that would keep these caregivers just at their side. On the other hand, they're as human as the patient as well. So talking to the patient and letting the patient know, listen, don't take it for granted, because I have seen elderly getting divorced. I have seen people, like, as soon as they know the significant other have a diagnosis of that sort, they would just leave. Because it's not an easy job, let me tell you. A lot of things start to be in your plate as a caregiver. And everybody thinks that you're going to be able to handle and that you have to do it, and that's not true. You choose to do it because of love, is what I would say. However, unfortunately, I get to see a lot of conditions happening in the caregivers. For example, I do have a patient that have a lot of hallucinations, have Lewy body actually, and the caregiver was the one who passed. He couldn't handle the situation anymore. The amount of stress and the amount of things in his plate were so much that actually during one of the hallucinations of the patient, he had a heart attack. So think of that, it breaks my heart, but that's the reality. And how much resources are available for the caregivers? There are not that many. I mean, there's some, but like the support group and this and that, I don't think that's enough. Caregiver burnout is huge. And there is a huge impact in the economics of the country in general. And I'm going to tell you the example of Alzheimer's in particular. We're talking about billions of dollars, billions with a B, that caring for an Alzheimer's patient means for the community. Now, Medicare and the insurance will pay just a small amount of this. The rest is coming from the caregivers, and not necessarily from the money that they put on the table, but from the time that they are not working, or they have to reduce, right, the amount of work that they do, how many forms of FMLA, of family medical leave that I have to sign just because they have to, they cannot work that many hours because they have to care for their loved ones, or how many times they don't sleep because, their loved ones are just wandering around. So this is a huge thing, and it impacts the economic, it impacts the quality of life, it causes more burden and more even diseases on these caregivers, and we need them around. The patients that I'm talking about, these neurological conditions, at some stage, they just cannot be by themselves. So how do we care for them is very important. Actually, we have a symposium coming up here in the Aleph, here in Lake Nona, and it's a Parkinson's symposium. And my talk, I choose that to be for caregivers. So my hour is going to be on caregivers, and I'm going to be a moderator. I have 2 caregivers that I appreciate very much. One of them is a young person, a young woman, that she's in her 40s, and I actually diagnosed her husband when he was 46 years old with Alzheimer's. Do you think that at that age, when we are, having a cup of wine or a glass of wine and eating, at that same age, she's taking care of her loved one that is still young. They don't have kids. She's just there because she loves him. And so she's going to tell that story for her and how she handled it and how she managed that at a young age. And then on the other hand, I'm going to have another, so this is a gentleman, a man that his wife had Parkinson's. She passed already. And I would like you to hear also, or the public to hear, the perspective of how a man handled being a caregiver and how he went through all those stages, because I think as a community, we always see the caregiver as a female. Mm-hmm. So that's why I try to put both on that symposium. So how he managed through those stages, going from walking to a walker to like everything that happened, and less than a month ago, unfortunately, she passed. So given the resources available in the community, not only from the association, so the Parkinson's Association of Central Florida, the Alzheimer's Association, they do have some resources for that, but also from the community itself, et cetera. We're gonna be talking about that. I think we just have to, this is a real thing, we just have to continue to educate, and getting more funding for this is a real priority, because it's gonna be it is a problem, not only for the family, but for the government, for all these people calling that they cannot get to their job because they're taking care of the loved one. And we're gonna have more and more people. So the prevalence of these conditions is just going higher and higher. So it's a social problem.
Indeed. Well, I knew this was gonna happen. It always happens when you're having a great conversation. We're out of time, but I wanna give you a last word. The title of this podcast is 3 Thoughts On, and today is 3 Thoughts on Neurology and Prevention and Disease. What 3 things would you want to leave the audience with after this conversation that we've had?
Yeah, so 3 things would be educate yourself, educate about like the new things that are coming, prevent, and in prevention, everything that we said, okay? And the third one would be don't lose hope, because a lot of things are happening, there's a lot of discovery, and I think we can be able to live a better life and a healthier life.
Dr. Urbanez, it's been a pleasure. Thank you for being my guest in my podcast. Thank you all that were online. We will be back here again in 4 weeks, the first Wednesday of every month. Thank you very much.
Thank you.